First of all, I'm delighted to be here with all of you, and thank you for the organizers for inviting me. Who I really am is I'm a bioengineer by background that happened to stumble into healthcare, and my first engagement in healthcare was actually consulting with Kaiser and IDEO on a nursing workflow study. Ever since I went through that, I fell in love with the entire space. I felt that there's a lifetime of problem to be solved in making things easy and simple for all of you, and have ever since devoted my time into that. And Brenda, one of the organizers here, know that I often joke that I'm still working on my nursing degree as the process of shadowing all the nurses. So what I wanted to share with you today within the next 45 minutes or so is really to share some of the ideas and patterns that we as a company have observed over the last 6 years of deploying mobility into the broader healthcare environment. A little bit about PatientSafe. I was told that don't give you the full demo of the product, so what we'll do is try to verbally describe it a little bit. What we do is to provide the nursing team and the allied health professional team with a single application that's deployable on any of your smartphones. But what that application does is integrating with your EMR, integrating with your telephony, network, and call systems, and deliver all the workflows, collaborations, and documentation features all on one device, one application. And what we're working on now is expanding that across our 80 hospitals and quickly growing into about 100 to impact the transitions of care as well. So we didn't get here by sort of just working with the hospital and dropping an application into your tools. We know that's a recipe for failure. We got here with really a ton of scars in our back, and that's why we wanted to share some of the scars on our back with you today and hopefully get some feedback and dialogue right after. The title of this talk is really the journey towards mobility as a perspective of what's in the past, what we're seeing as far as people are dealing with in the present, some of which we've actually heard Ellen from UCLA describe, which are very exciting about a series of things that we're trying to do to make nurses' life simpler and more effective over time. So first of all, why having a mobility strategy in the very first place? I think all of us in the audience here with a sort of an informatics background are grappling with two sides of a similar coin, actually. First side is the frontline care team generally are tired after decades of EMR implementation and a lot of documentation that are bound to it. And that gradual fatigue is driving them to demand better and better ease of use on their mobile devices to get through their workflow and communicate with the rest of the care team. In order to do that, the demand on informatics professionals that are in the audience here are quite immense in terms of having easier access to data. But the other side is, in an attempt to address those demands that are coming in from the front line, oftentimes what we did, and at least what we saw the entire industry grapple with, is proliferation of more devices and more apps. We think that's actually not necessarily the right solution. If you are setting out your journey to simplify the experience of care and finding effectiveness between the delivery of care and the collaboration of care, the goal should be continuous consolidation and get less devices into the point of care and get less application onto your phones that way. These numbers, hopefully over time as an industry, will work hard together to solve for, but there's a recent study in Wireless Trends saying that average number of mobile devices clinicians interact a day to complete their shift sometimes is 6 different devices. They sometimes count the workstation on wheel in it as well. And across those devices, probably 5 different applications at any given time on your smartphone today that are work-related. The converging demands on IT, this counterpart of a lot of our audience in the room here, having to grapple with the converging demand across security, productivity improvement, safety and quality improvement, and the broader and ultimate dream of how do you leverage mobile devices, mobile application framework to get to true coordination of care instead of all the segregated silos that you're experiencing with today. So what are the elements of the mobility strategy that we observed? We don't proclaim this as any proprietary framework at all. Every one of you know these slides probably ad nauseum here, but it's really, really, really true that it has very little to do with technology. In our 6 years of deploying across 80 hospitals, we found that 80% of the success of an entire project for deploying mobility into the point of care has to do with people. And any project that doesn't go as well, or the use case doesn't get extended as well, or somehow the reliability of the tools underneath is coming into question, to Ellen's earlier point, getting a system purchase is only your first phase of it. The rest of your life sort of began right after that, especially for the folks in the audience here. I think all of us, when we think about mobility, should start to think very broad now. and think about it horizontally and think about vertically. I'll talk about what we mean by that. We want to think about a design process that's actually all-intensive and all-inclusive. What that means is we want to get your institution stakeholder involved from physician, nurses, pharmacists, all the ancillary staff, IT, clinical informatics, as many different unique personas as you possibly can get. And the idea there is to capture the right workflows as cross-functionally as you can, especially at the points of handoff and points of coordination, right? Lots of terrible things go wrong there, as you well know. Next is, what are the ideal experiences that they're looking for? And everybody has slightly, although they like to tell you they have slightly different requirements and experiences, at the end of the day, there are a lot of common patterns if it can truly facilitate that kind of conversation across your institution that way. Through those conversations, a lot more of these horizontal workflows can be mapped out so that you don't just optimize mobile technology for a particular audience. And next up is really, once you get people and processes identified, across the technology stack, we want to examine deeper and deeper how do you get vertically integrated in terms of the capability at each layer, from the apps that you deploy to the devices that you deploy to the mobile device management vendors that you deploy, middleware, network, and deeper into the infrastructure. How do you draw a line that's really vertically across there and understand what are the capability gaps and what are the forward compatibility strategy that you should be thinking about in order for mobile to be effective and in order for mobile to be more than just a piece of tool that ended up gets stuck in a biomed drawer somewhere over time. And second part of the mobility strategy really across this is this picture a lot of you are probably intimately familiar with. Looking at your technology stack is not enough. We believe that you should never look at your technology stack that are separate and away from the boxes in green here, which is what type of workflows are you truly trying to enable, and over time. Don't try to enable everything at once, right? And what, more specifically, workflow is not enough. For the workflows that you're looking to enable, what type of outcomes are you targeting to get out of those workflows? And really talking about it in conjunction with your IT stakeholders, with your telecom stakeholders, to look vertically deeper and deeper down the stack about what type of mobile application makes sense, what type of mobile device form factor makes sense, and we heard Ellen from UCLA mention that earlier again. What type of middleware makes sense, and you may already have a lot of things already invested, and what type of device integration strategy makes sense across it, and do you really have an infrastructure that's fully supportive of that? By infrastructure, I mean clinical application infrastructure, mainly your EMR investments, your network infrastructure, the aging of that, the wireless, the telephony, and all of that that combines with it. The ultimate goal, as we examine sort of the past, present, and future, using these two frameworks, is horizontal integration should be the pursuit for workflow and experiences. Only when workflow and experiences are accounted for across this broad group of people can you really target after outcomes and productivity. The reason why so many projects that couldn't generate enough ROI, our esteemed panelists earlier on had talked about as well, is we rarely begin with the targeted outcome in mind before deploying a piece of technology, and we rarely look at, once the targeted outcome is in mind, what type of vertical integration to the extent is possible and over what type of a time horizon. So I want you to keep these two frameworks in mind as we look at the past, or for some of you, this might still be the present. Come talk to me if that's the case. In the past, this is the picture that we know of, right? Mobility strategy, probably A, is not really a buzzword in the past, and B, tend to be reactive management. What I mean by that is people think about what type of application to enable, regardless of sort of the workflow conversation a little bit, and it tends to be single purpose. A single application for the workstation on wheel just so we can chart and administer medications perhaps along the way. That's as multi-purpose as it gets. Some of you remember motion C5s. Who remember motion C5s in the room? Right, who still have motion C5s in your hospital? I'm glad no hand raises out in the room. And then people tried with these old bricks of devices before, right? The pursuit for mobility has always been there because healthcare delivery is a fundamentally mobile and dynamic and real time where the work gets done type of feeling, right? The typical productivity tools from our IT world tend to be locking us down in front of a desktop, chart, click, type as many of those as possible, but that's fundamentally incongruent with how we deliver care, right? There are time and places for that, but the majority of the high frequency, short duration workflow that strings together the entire experience of care are fundamentally mobile in nature. But we also separate clinical and communication care. Clinical care is single-purpose devices on one hand, communication single-purpose devices on one hand. Now, raise your hand if any of those devices on the communication end still lives inside your institution today. So good, I see actually a lot of hand there. In the past, when we deal with these devices, the selection of the devices, the selection of the application that runs on these devices are reactive in nature. And what do I mean by that? It's typically a siloed ownership, right? Telecom and IT may come up with a strategy around to say how much of the paging devices to be retiring over time and how much of the wireless phones to be refreshed over time over in what areas. Nursing oftentimes have a completely different view of the utility of these devices, right? When are they more useful? When are they less useful? And physician oftentimes is a completely different end of it. Just give me exactly what I need when I need it, not announce less, not announce more, right? And also when I need to reach someone, please allow me to go do all of that. And in the past, I believe all of the mobility conversation, unfortunately, are maniacally focused only on one layer of the stack, which is mobile device only. What would end up doing that is that hospitals also tend to be slow about maintaining and replacing some of that. I see some laughter in the room already because you've probably seen this before. If you invested in something, I encourage you to go down to your biomed team and ask them to show you the break-fix station, right? How many of the duct tape devices across the spectrum are you really seeing? And the break-fix burden across the proliferation of devices are sometimes the hidden costs that at the CIO level, at the leadership level that we don't talk that often about. And the siloed ownership in the past tend to be either in biomed or either in IT that are in response to something breaking or in response to something that are being replaced piecemeal that way. Using the same framework to talk a little bit about the present is that healthcare has a way of sort of a warping time, right? What I meant is it has a magical way of stretching the timeline longer and longer. As soon as you put a piece of technology into the point of care environment, into your hospital environment, somehow that has a way of extending its useful life, right? And what happens currently is while these new technologies are coming into your hospital environments, smartphones, tablets being two of them, it really excites all of our imagination about all the possibility on it, right? We use it in our consumer lives. We see it outside of healthcare being adopted to sort of amazing levels of productivity, and we're very, very active as a whole industry to figure out what we can do with these devices. The intention there is ultimately you don't need all of the legacy devices that are single purpose anymore, right? Hopefully retiring the previous picture with just the smartphones and tablets. For your inpatient staff tends to be institution managed, institution issued. For all of our physicians, forget about really asking them to carrying multiple devices ever. Just ask them to support the devices or support their devices they're carrying with them. While that is exciting, I think we are still in the present time struggling with the fact of how to react and adapt to these smart devices. Our networks sometimes aren't designed for them. Our medical devices, the alerts of which aren't designed to really to be outbounded appropriately to some of these. And as soon as you begin to grapple and react again, the fragmentation of the experience continues, right? The infrastructure readiness sometimes is what you have to wrestle with. And in fact, in a conversation with Ellen right after her presentation, as well as during the panel you have all heard of, she purchased a set of devices. She purchased an application to support these workflow and communication. But now the real work sort of begins about how to make it less fragmented, about how to make the EMR vendors sort of introduce more capabilities onto it, and whether the phone features and capability of itself simply can work on the network or not going from there. So what are we seeing right now? What we're seeing right now is even more devices into the hospital, right? Those old devices aren't necessarily going away yet because we still see them floating around. These devices are coming in, and people would prefer to use them, but not enough to the application, not enough to the workflow, and not enough to the integration is really being considered. What that leads to is as soon as you give a smart device to the clinician or to a consumer that way, more ideas come up. And those are oftentimes great ideas. So one hospital we recently visited have found that there's a proliferation of disparate apps created a new virtual tool belt, right? They were setting out to get rid of the physical tool belt by the nurse. No more pager, no more phone, no more separate barcode for specimen, no more workstation on wheels in a lot of the different settings. That's actually a great goal. However, they realize productivity doesn't necessarily improve from that point on, and context integration, right? Speaking of context integration, nurses are one of the most amazing people on earth in that they're able to keep together so many moving pieces in their head, right? Thank you. And they are really the unsung heroes of primal integrators of care. At least that's our belief, because they have to piece together what happened down in pharmacy, what happened down in radiology, what happened down with the physicians. Physicians, no offense towards that, you do look at a wide panel of data to make some key decisions that facilitates the workflow, but the execution of that particular workflow and the result of those data oftentimes are time critical and dependent on the extended disruption you introduce to the nursing staff, right, as a whole healthcare environment that way. So when you give the nurses the powerful devices to carry out their work, but they have to switch between 5 to 6 different applications to access some of the context, that still defeats the purpose. Information gets lost, the alerts are sitting in one app and not available in another. And then sometimes, nurses gradually, I call it the nursing toe tap test, right? As soon as within one toe tap it doesn't get done what the nurse is intending to get done, getting into the patient's room, she tosses it away. And workarounds sort of ensue from that. They know better about how to manage across the workflow that way. Here's the challenge currently, because we're still seeing, healthcare also have a way of extending the same metaphors in the past, right? We love to tell all of our clients and all of our partners and all of our consulting engagements that, look, Apple didn't really design the iPad by shrinking down a MacBook. They didn't start there, right? So don't give a spreadsheet-based sort of application shrinking down more and more, slap a Citrix on it, and then all of a sudden you're great to go, you're mobile enabled. That's not our worldview. And then the second piece of the evolution there is people still think that with smartphones, let's virtualize the pager, let's virtualize the wireless phones, let's virtualize all of those legacy devices, right? I've shown about 6 different devices, 3 on each side in the past. And I think the same thing are now being virtualized on your smartphone into its individual apps. Secure texting is oftentimes its own standalone application. Your voice client is oftentimes a standalone application. And your clinical documentation tools are yet, again, a separate documentation. The reconciliation between these two, clinical workflows and communication workflows, I think is what our industry is grappling with right now. And I really hope that more and more informatics minds are getting involved in the picture and improving that over time. The other phenomenon that's happening is we also have some of the old infrastructure that are in place that doesn't go away overnight, but needs a more purposeful way of building a multi-year roadmap to support reliability and interoperability across the infrastructure in that vertical picture is also something that we as an industry are now still grappling with. This picture is actually a live sample from a consulting engagement that we recently did with a partner. This is a 30-hospital system that we examine across the vertical stack here to start with their network and telephony layer. How many different network and telephony providers they have for unified communications, wireless network, Wi-Fi access points, how many different vendors they have in patient monitors and nurse call systems, old and new, how many different middleware players they have because they have to introduce the middleware to get all of the disparate systems. Middleware's great promise is really helping you getting all of these alerts to the right places, but in so doing also extend the livelihood, again, of all the underlying legacy systems that are in place. And what are all of the different alert and notification management? What about scheduling, right? Physician in particular, the on-call schedule piece is more magic than science at this point in time, right? I oftentimes love going into the implementation, asking people, how does your physician manage their schedules and how does the rest of your care team really figure out all of that together? And it's a really, really complex science behind that as well that are further complicated by siloed investment across all these different places. And then we get to the more exciting layer where we can touch and feel and we can all work with, in that there are purpose-built inpatient devices right? Where again, they serve as a functional purpose, scanning the barcode, doing something. Or they're multi-purpose devices like the smartphones are capable of doing now. You can scan a barcode with just the camera itself and get rid of the barcode imaging scanner that way, and then be able to do voice, text, barcoding, documentation, and hopefully a lot more going on. And then I actually particularly resonated with the doctor's comment earlier on, because it's so easy these days to come up with an idea and have a low-cost way of getting some open source software to build a new app. Anybody and their cousin can build an app, I guarantee you that. But getting into healthcare, all of a sudden we see an explosion of the apps out there, right? At some point in time, it will settle into different platforms. We call them systems of engagement and systems of workflow. Hopefully over time, this transition from past mobility investment to the present mobility investment to the future mobility investment has less fragmentation and purposeful consolidation at every layer of this picture. But if our current mobile emphasis is only around smartphone adoption, they're coming into our hospitals, we have to respond, make them secure, make them reliable, and make sure our network don't crash. And again, the ownership is siloed, right? You'll have IT, you'll have telecom, sometimes you'll have nursing, but we do see more and more physicians are sort of putting their foot down about getting the reliability out of all these experiences. So the focus is expanded beyond just the device from the past. It's now which device for which app is better and more appropriate for what type of setting, right? The ultimate pursuit for that one app everywhere, actually we've seen many people attempted to set out on that journey, but very quickly realizing that that would not be the right focal point. The right focal point is the appropriate app, appropriate device for the appropriate workflow and for the appropriate outcomes and experiences that you want to generate, because there simply isn't a single platform out there that can do it all. And if you want to do it all and not making it open, gradually you're creating fragmentation as well. We still have limited workflow impact for all of the existing app choices that we make for communications. Other than being able to virtualize a pager, being able to virtualize some of the sort of the texting capability, there are not many people that can legitimately look you in the eye and tell you there are real ROI besides sort of device and application consolidation. Primarily because these aren't integrated into our clinical workflow, right? Anything that's not deeply embedded into clinical workflow in the present time for mobility have very low to no outcomes impact. It's very hard to tell whether introducing these applications have fundamentally changed your care delivery environment, and it's harder to tell if the ownership of these applications is scattered all around the place, and it's even harder to tell when none of the design begins with what outcome are you targeting, and what types of workflow are you enabling that way. Worse yet, the current environment also have to deal with the fact that consumer devices are moving into our enterprise-grade environment, but they're going through their own cycles of evolution of getting this favorite phrase a lot of CIOs love to tell us about is enterprise grade. What exactly does it mean? Is it reliable on my network? Is it easy for me to manage? Right? Can I wipe the devices remotely and follow all kind of the protocols all around that? Right now, because of this forces of consumerization of the IT coming in and some of the underlying readiness for our infrastructure, we struggle with introducing smartphones into our hospitals. Now, talk about the future, and I believe this is actually a very near-term future, because as our consumer lives getting more and more proliferated with these consumer-grade experiences that are delivered, to think about it's actually quite powerful. Every single app on your home screen right now is actually a unique service that's delivered over the cloud. Uber is your ride-sharing service, right? Calendar is your calendar and scheduling service. Email is your communication service right now. What if inside healthcare, there are a more purposeful conversation around mobility that are much more than devices and apps, but really about what's the right set of services you want to empower your frontline care teams with to simplify the experience of care and find the effectiveness of care for your patient and improving efficiency, productivity, and outcomes that way. We continue to believe the industry will evolve towards this direction, which is a lot more conversation before investment in any mobile device application or application around horizontal integration. What do we mean by that? The right workflows across physician, nursing, clinical pharmacists, allied health professionals. And bring the patient into the picture is even more important in that to say what type of demand and what type of experiences, what type of sort of a responsiveness you want to provide to what type of patient, and the care team will sort of rotate around the patient as more of a dynamic state that way. And if it occurs that way, what type of horizontal integration you need on the workflow. How about the handoff between the nurses in between shifts, right? A decade-old problem that we're still finding more and more scientific way of addressing. What about the nursing to physician communication about the context of the patient, right? For those of you who have adopted sort of secure messaging, you will probably resonate with this particular experience. A nurse texts a doctor probably during the night shift and say, hey, pain meds for this particular patient really isn't responding, or patient in room 302 isn't really responding. Would you change the order from Q4 hours to Q2 hours, right? That happened quite a bit. What we observe quite often is, again, single purpose messaging application without consideration for workflow, without consideration for any of the integration kind of come across. The doctor texts back, who are you talking about? And then the nurse texts back, oh, the patient in room 302, which patient is that? And then go back and forth, and then say, give me the last vitals, what exactly is all the lab results came back, what has happened over time. 17 to 27 messages are exchanged before context can be passed around, right? What if in the near future is that as soon as you send a secure messaging, it integrates with your EMR that comes with the patient automatically tag, and we actually saw some of that from Ellen's presentation that way. The doctor that receives the message will be able to immediately see who are you talking about, and within a very conducive form factor, access to all of their data without leaving that single application. And as soon as he wants to trigger something, right, it's actually integrated with the order entry system. It's actually able to, if he needs to pick up the phone to call somebody else, it's all done within a short span of time and no context is lost. And all of those contexts requires more and more horizontal integration, and the workflow complexity increases the more of the persona you add onto the network that way. Talking about the vertical integration, how about the interoperability between these layers of middleware, nurse call systems, and all the infrastructure? We actually see some very exciting signs happening in the marketplace today. Cisco, many of you probably have them because they're a large market share provider, actually are doing some very innovative things on making sure their network are optimized for smartphone, right? Meaning that no more drop calls. How do you enable sort of the access point sensitivity towards that? How do you give certain application sort of privileges to make sure that they can get passed through the data packet faster than others? Middleware vendors are gradually evolving sort of into the endpoint because they realize you can only be a middleware for so long, right? The true utility of that is as soon as the medical devices over time that are coming into your hospital system are already smart enough in and of itself. Many of you have heard of Welsh Allen's spot monitor vital signs checking devices that are already smart, well integrated with your EMR. With all of those pieces that are, again, done within their specific context, if we can get all of you in the room and all of our colleagues in the industry as informatics professionals to really come together about recognizing that after 2 decades of EMR investment, medical devices investment, network investment, it is time that we think about what's next after systems of record has been in place. What do I mean by systems of record? Your electronic medical record. Your phone tree is actually another system of record. What are all the extensions and who are all the people along there? And where all your assets are, if you have invested in an RFID system, still a system of record, right? Tagging of all the people and places that are involved in it, and all of your patient IDs that are floating that, still systems of record. Mobility services, if you're serious about improving the productivity, easing the access to all of the data and getting the better outcome from that, needs to be thought of as services that are fast, agile, that are built on top of these systems of record, right? If there's a layer of interaction that are constantly mobile, practically ubiquitous, regardless of which setting you're in, we can really drive reliable outcomes by getting the right workflows enabled across the horizontal integration and getting the right interoperability protocols developed. And I see the industry actually actively getting to that. That gives it a lot of hope to begin to really, really have horizontal and vertical integration. So a picture might look something like this, that you're probably already embarked on the journey, depending on which corner that you're approaching. All of these discrete systems in your clinical infrastructure, ADT, CPOE, pharmacy, EMR, patient flow sheet lab, and the fundamental care team concept, right? Some of you probably still struggle with where should we define assignment of the patient to a particular clinician? Does it sit in the EMR? Does it sit in your scheduling system? Does it sit in your nurse call system, or does it sit in yet something else? I think, again, we need sort of a broader normalization of that, and it's coming. The alerts piece is actually well developed in the industry now. We're probably in its 4th generation of the evolution of all of that. I have high confidence that more and more innovation will be coming out of that to make it a lot more seamless for you. What about thinking broadly beyond inpatient telephony? What about thinking about how, when the patient leaves the hospital, you would be able to integrate with all kinds of different telehealth services that are more and more available now? And an integrated ecosystem, what sits in the center represents your strategy as clinical informaticists that really are beginning to take a leadership role in defining what mobility can do. Because at the end of the day, what's after EMR, what's after data warehouse investment, what's after all the unique technologies on sensors and all of that, I think we need to get back to where the work is being done. Point of care, that unique moment of interaction between you and your colleague, that unique moment of interaction between you and the patient and the rest of the care team. I think healthcare is really stringed together by these unique moments of need and moments of interaction. And how do we remove all of the friction in those moments? How do we give the right context to the right people at the right time, the ultimate pursuit of informatics, right? And do our role to really evolve the industry forward a little bit more. I think it comes down to this. Anytime when you deploy a mobility strategy across, it's 80% about people issues. Do we have the wherewithal to have those conversations where the barriers are? I love what Ellen said earlier, that UCLA is a slow place. It takes a lot to get consensus, but she was quite dogged and continued to push through that. I think that's what we need. And I see an increased responsibility in clinical informatics professionals to tie together all these silos over time, because in the past, mobility project has the following challenges. Siloed ownership, that could come from anywhere in the corner. Is it a clinical initiative? Is it an IT initiative? Is it a telecom initiative? Sometimes unclear executive sponsorship, right? Did a CIO sponsor for that, CMO sponsor for that? Or rather, it's really delegated to just replace some devices going forward. And lack of strategic visibility, right? It doesn't have the fancy phrases of population health attached to it. It doesn't have the other fancy phrases of all the clinical outcomes tied to it. So who would give a damn about mobility? But yet, if we're focusing on reframing the conversation to say, mobility is about enabling you to do work. It's about enabling you to string together those unique moments of interaction, make it easier to do the right things right, first time, every time. That's when the outcome can be really quite dramatic, when we have a successful mobility strategy in the future, where a strategy, first and foremost, is well defined. Oftentimes, we see the most successful mobility projects out there are led by CMIO and CNIO collaborations. And we've seen many sort of institutions that have deployed our solution before that previously did not even have a CNIO position. Over time, after deploying this across, have gradually created more and more CNIO positions. Consulted oftentimes by the CTO, who are experts in the device form factors, the reliability of it, the existing limitation of your infrastructure, and how to think around that and plan a roadmap and strategy that are oftentimes sponsored by the CIO. That's automatically another improvement in the likelihood of success of such strategy. And cross-functional stakeholder. It's almost trite to begin to mention that, but if you can actually bring that truly together and begin with the experience design about workflow. Identify all your vendor consolidation requirements, because the idea is to make it simpler over time. And develop a clear, and I still advocate for this, if any vendor, including myself, come to you and say, look, all of your problem will be solved within a year, don't listen to us. Don't believe that, okay? It needs to be a clear multi-year roadmap with purposeful evolution that starts with what's the single biggest constraint that you're trying to remove out of your infrastructure today. What's the single biggest constraint you wanted to deliver from the experience side? And really gradually look at that, because working on anything upstream from the constraint and downstream from the constraint oftentimes simply doesn't add a whole lot of value. And whoever sponsors and champions some of these initiatives, successful mobile-enabled institutions are relentless about the results. you should always begin the vendor selection process, the sort of a strategy process with, let's begin with what type of results that we want to accomplish, right? On the clinical side, what is it? For communication, do we have baseline definition of what inefficiency is? For the clinical workflow side, do we have all of the canonical definition of quality, as well as now with the EMR investment, a lot more meta-level definition about we're getting data, but sometimes there are false positive data. How often are we having still gaps in care due to the lack of ability to get the data to the right places at all times? I'm just illustrating that these are some of the results some of our clients have accomplished, and some of you are accomplishing through other systems as well. And what that bodes for us as a journey to mobility is, I believe in the role of clinical informatics. I believe clinical informatics plays a super critical role in tying together the historical context silo and define what mobility could be. And I believe mobility needs to be discussed, planned in the framework of starting with your targeted outcome and starting with the targeted workflow, and then break apart on what a multi-year roadmap looks like. So I know that's rather rapid fire, but I'll pause there and see if there's any questions.